Hello, folks. Welcome to Clinical Supervision Training. This is the advanced training. This is part 3 of the series. Hopefully you have seen part 1 and part 2, either on Relias or the live version that was taught when it occurred. This is only going to be available through Relias as a recorded training, so there won't be any live interactive version. So thanks for joining. You will see my little avatar up in the corner here as we progress through this training. So at the very end of this training, there'll be some ways that you can get in touch with me to ask questions or to have some questions asked of your supervisors, should you have any. Today's agenda, we're going to review some of the learning objectives. These learning objectives were for all 3 of the sessions. So we'll have accomplished some of these learning objectives by now. We're going to review clinical supervision part 1, which was the basic training, part 2, which was the intermediate training. And then today we're going to look at some of the stuff that we're going to do for part 3. And then we'll have a wrap up, which will have some of the things that we are going to do moving forward. And then some ways that you can have some of your questions addressed, should you have any. These were the objectives for the series of trainings. Objectives for clinical supervision trainings in their total. Want to remember the reasons, the basics of why we were called to supervise. Hopefully we will have developed a better understanding of the job and the purpose behind clinical supervision. Learn how to apply some of the ethical codes to clinical supervision practice. Remember, we went over these ethical codes pretty extensively in our first training. We want to learn how to critically analyze the literature on clinical supervision models, which we went over in part 1 and part 2. Evaluate which clinical supervision models would most benefit our counseling staff and in turn most benefit our patient care. And we're going to go over those a little bit today as well. Those were really extensively went over in the second part, but today we're going to go over the ones that are likely the most popular and the ones that we'll most likely see. And hopefully in total, this will have created some cohesion amongst our clinical supervisors and the supervision being provided to the clinicians throughout our organization. So this is a little review of clinical supervision 1. This is our basic training. We started off with a extensive self-assessment. We learned about what proximal and distal goals were. If you remember, the proximal were close and the distal goals were a little bit further away. Goals that were a little bit closer to us, or we can think of them as short-term goals. And these were more long-term goals. And as far as supervision, we talked about supervision with our staff as being the place to discuss tough patients or patients that are not easily conceptualized. So a little bit more difficult to deal with, or patients that we don't see very often. An area that we want to discuss patients that cause counselors to pause. And I just use the word pause as a spot where counselors really don't know exactly how to deal with the situations that come up. Or maybe their first inclination is not the exact thing that their first thought, maybe not the right action to take. Clinical supervision is the place sort of to discuss ethical considerations that may come up. Definitely the place to discuss multicultural considerations. This should be an ongoing part of our conversation with our supervisees, and potential blind spots. I like to use the term blind spots because oftentimes these blind spots are not intentional. Just like when you're thinking about a blind spot in a car, it's not something that you are intentionally avoiding. It's a blind spot. It's a spot that you're not thinking about there. And as you continue to drive that car more, and as you continue to be more familiar with that car, that blind spot is something that you begin to recognize more frequently. And as you begin to recognize that spot, you begin to understand that it comes up and you begin to accommodate for that spot. So having that discussion with your supervisor. It's also the spot where we want to discuss growth and gatekeeping. We want to be gatekeepers for the profession. So if something is coming up that we want to be able to discuss and have those conversations with our supervisees to make sure that we're allowing people to come into the profession that are ready for the profession, that are going to be good counselors, and that are going to be good for the patients and good for the quality of care. So as you can see in the bottom corner down here, no, clinical supervision is not human resources. It's not the same as administrative supervision, although in some cases, some of the duties that a clinical supervisor may have may end up overlapping, which is fine. But by and large, it is not administrative supervision. It's not conflict resolution. We want to make sure we keep that in mind between two counselors. Remember, we have a great human resources department at Serenity Lane, and we want to make sure that human resources handles human resource issues. It is definitely not supervisees' personal counseling sessions. We want to draw boundaries early on in the counseling or the supervisee-supervisor relationship. We want to make sure that folks know that that's not their counseling session. There's been many times in my time in the field that I've said to somebody, I am a counselor. I'm just not your counselor. And folks need to understand that. So drawing those boundaries very early on. I say this, and it's not a joke. It's not a dating service. I want to make sure, just like clients are not supposed to date each other, counselors are not supposed to be dating their supervisors. The last one is not an opportunity to make friends. Of course, it does happen. We shouldn't go into it with the look like we were supposed to be making friends with folks. Can friendships develop over the course of working together? Of course they are, but the first rule of thumb should be that we're doing this with a supervisee-supervisor relationship, and we should be there to help coach folks and to make the very best, help them make the very best counselors that they could possibly make. During clinical supervision 2, we discussed 3 primary things, although this is a lot. The review of clinical supervision models. We discussed models that were grounded in psychotherapy, developmental models, and process models. So of all of the models that were discussed, developmental models is the least, or are the least popular. So I'm going to put a 3 there. They are the least popular. Process models and models grounded in psychotherapy are generally the most used, but if one had to be the most popular, I would say that this is the most popular and this is the second most, although the literature and the studies that you read may have those backwards. So for the purposes of what we're doing right here, we'll say that these are a tie. But definitely developmental models are the least popular. And you will see why in the next slide, or the next couple of slides. Of all of the models that were grounded in psychotherapy models, I picked the 3 that are probably the most popular in substance use disorder treatment. The humanistic relationship model by Carl Rogers. It was expand the capacity for self-exploration, didactic training from recordings to see natural tendencies. Carl Rogers really encouraged folks to record and watch that back. That empathy and warmth are essential in supervision. He very much encouraged these concepts to transcend not only the counseling relationship, but also the supervision relationship. The cognitive behavioral model, we tend to think of Ellis and Beck there. The thoughts, attitudes, and beliefs, you can recognize those terms from CBT. Influence, actions, and behaviors, once again, very CBT. Classic and operant conditioning, adaptive and maladaptive behaviors. Whenever you see that, you should automatically be thinking CBT. Agenda and homework and assessments with supervisees to measure change. All of that is very much CBT. We think CBT, whenever we hear those words, those are very CBT. Whenever we think of assessments going into supervision and assessments coming out of supervision, that's exactly what we think of. And then we have solution focused. Patients know what's best for them. There is no single way to view things. We focus on the possible and the changeable. Curiosity is essential. Presuppositional language. Tell me about the last time that you were able to be assertive with your patient. So we're using that same solution focused brief therapy, language that you recognize from solution-focused brief therapy with supervisees. So we can see why that would be so popular. These are just 3 of the ones that we would see the most popular models grounded in psychotherapy in use with our supervisees and in use with substance use disorder. Ironically, I have a little cartoon of a little caricature of Freud in the corner here, and he's not part of the most popular ones, but he's there anyway. Then we have developmental models, and as you may recall, there were many models involving steps and stages and phases and whatnot. It's difficult to remember. Some required mapping. Some of them were 14 phases and 13 stages and 11 steps. It's tough to remember. Here is one of those developmental models, and here is another one of those developmental models, and here is Nick's question marks in the center. They're difficult to remember unless you have them all mapped out. Once again, these are Nick's question marks. They didn't come with the developmental models, although I believe some should have. But like I said, sometimes they're difficult to remember, especially as a substance use disorder counselor. They may be one of the last things for folks to grab a hold of. They might be good for review. There might be some things that we can glean from them. But like I said, they have a tendency to be sort of the last things that people gravitate towards. Of all the process models, Bernard's discrimination model tends to be the one that is the most popular. It also happens to be the most popular with mental health counselors as well. It's Bernard's discrimination model. This was 1979 was when Dr. Jeannie Bernard came out with this one, 1979. This was based on 3 foci and 3 roles. And you'll see that the roles are right here, and the 3 foci are right here. And these are the roles of the roles of teacher, counselor, and consultant, and the 3 foci of intervention, conceptualization, and personalization. And Dr. Bernard believed that everything that was discussed in supervision, everything without fail, fell into one of these 3 foci and one of these 3 roles here. And so as an example I gave, here is an example of how you could have in supervision. So your role as a teacher in this particular example, but as far as a focus of being personalization, the teacher teaches the supervisee about transference and countertransference. But as a counselor in this personalization category, the supervisee is dealing with imposter syndrome, and supervisor processes session with supervisee. So even though our job is not to act as a counselor, we could jump into that role in order to process the session with a supervisee that's dealing with imposter syndrome. And more as a role of a consultant, the supervisee discloses that they have romantic feelings for their patient. So you can very easily see by that how that the supervisor could be into all 3 of those roles and all 3 of those foci. So this is a process model. This tends to be one of the most widely used process models that there is with respect to the supervision models. So that's the review of clinical supervision 1 and clinical supervision 2. Now we get to look at how we're going to wrap this all up with clinical supervision 3, which is about putting it all together. Yay. How to teach and role model supervision. How top-notch supervision retains employees and patients. And then the importance of supervision documentation, which is hugely, hugely important. So teaching and role modeling supervision. Those of you who have been around a while probably remember a lot about social learning theory. Social learning theory, in essence, tells us what we teach by doing and role modeling. And if you remember, I'll try to draw it out a little bit over here. Social learning theory, we always remember as like these stair steps. And on this first stair step right here, we tend to think of these as stairs. What the first one we do is that we learn something, we watch something, and then we practice something in front of our peers. And then we sort of take this out to the community and see how that works. Practice it out in the community, whether that's in our systemic community, like in our group room or in our community at large. And then we take it back to our peers and we tell them how it went. And then we get feedback from our supervisors. And then we start this process all over again with a brand new skill. And if you think about it, this is exactly what we ask our clients to do, right? So we can, in essence, we're doing the same thing, drug refusal skills, right? So they practice this with us in group, take this out to the community, practice this with their peers, come back and tell us how it went. And we give them feedback, and they try it again the next week with something different. And all of this requires trust and a lot of rapport. Whoops, excuse me. Trust and rapport. And those are the exact same things that we do when we're teaching it and role modeling it with our supervisees. When we have the chance to do group supervision, we're putting the questions back to the group, right? So a question might come up with our group in our group supervision about how did you deal with X? How to deal with whatever the situation is. How did you deal with X or Y? And we might turn around and put that back onto the group of counselors. How did you deal with X when X came up? Or how did you deal with Y when Y came up? And they might be able to dig back to their wealth of knowledge and talk about how they dealt with X or how they dealt with Y, which, if you think about, is exactly the same thing that we do with our group members, right? Johnny, how did you deal with the drug refusal? Or how did you deal with the first time you went to Thanksgiving and Thanksgiving they started drinking? So these aren't new ideas to the people that we supervise. They're actually things that they should have been dealing with for a long time. During annual reviews, we're talking to folks about their goals and their future aspirations. We should be looking for interest in future clinical supervisors. And with such interest, we can be working towards that by assigning readings, tips from SAMHSA, Relias trainings, and then in subsequent clinical supervisions, follow up and find out if they took interest in that, and if they looked at those sessions and they read that publication, or if they were interested in that. And then we can hone in on that with professional development in future sessions. Homegrown supervisors are the best supervisors because they're doing it exactly like we want them to. And if we're not doing it, be assured that another agency will be. When we do this and we're training at all opportunities, we are creating top-notch workforces. And a top-notch workforce helps us retain patients and provide top-notch care. One of the things that's helped me tremendously in dealing with clinical supervision is exactly the same skill set that has helped me in dealing with having a patient load. When something goes wrong, or I feel like something is amiss, one of the words that's helped me tremendously is a rupture. When there is a rupture with my patient or with a supervisee, and it's just a good word to describe the situation when something is not going right. It's actually a word that Safran and Moran used in 2000, but they just expanded on the work of Bourdin from 1979. And Bourdin was actually the one that came up with these three: goal, task, bond. And he hypothesized that everything in a session was related to goal, task, or bond. And Safran and Moran used the same for supervision. They said goal, task, bond. Everything was related to goal, task, or bond. So what I'm encouraging you to do is to take a look at that. You don't have to go read the book, but if you chose to read the book is right here. It's called Negotiating the Therapeutic Alliance. It's by Safran and Moran. It was made in 2000. And it gives credit to Bourdin in 1979, who initially came up with this goal, task, bond idea. So challenges in supervision are the same as the challenges in counseling. are the challenges that you're dealing with right now, or are the rupture, is the rupture or the ruptures that you're dealing with right now, are the challenges related to the goals, are for treatment goals or supervision goals? Now, what we think of with this, goals, we tend to think of supervision goals or treatment goals. Now, this is treatment plan. Excuse my spelling, treatment plan or supervision goal. So what's the supervision goal? Which is different than what the task is. This is the task at hand. So this is where those words that we talked about earlier come in. These are the distal, and these are the proximal. No, I apologize. I just did this backwards. I apologize. These are the proximal. And these are the distal. Whoops, I apologize. I knew that didn't look right. These are the distal goals. These are the treatment goals. These are the long term. These are the short term. So the task at hand is the proximal goals. And then, or is the rupture that we're dealing with, is it the bond? So is there something that was said, or was there an event or something that took place that recently impacted our bond? So what is the rupture that we're dealing with the supervisor, the supervisee, or is the rupture that we're dealing with our patient related to goal, task, or bond? And it's really easy to surmise if the situation was goal, task, or bond. Simply looking back at the session, when did the rupture take place? And that's a pretty good, easy question to ask ourselves. When did the rupture take place? And based on that, did the rupture take place after the treatment plan? Did the rupture take place in our last session? Was it something that was said that made the rupture take place? And based on that information, you can sort of tell what the rupture was based on. And the advice and the solution is the same for all of it. The solution's right here. Step back, ask the questions, meta communicate. Meta communicate just means communicate about the communication. Hey, I noticed, Johnny, that after our last session, when we came up with some treatment goals, the communication between us kind of soured. It went a little like this. Did you notice the same thing? Re-engage, realign the goals or tasks, attend to the rupture, attend to the alliance, get everything back on track again. We don't have to let that sit out there. So once we meta communicate, we fix it. We re-engage or realign those goals or tasks, attend to the rupture, attend to the alliance, and move on. Letting it sit out there, the longer we let that sit and wait, the harder it is to fix that. There are really three types of situations that arise as clinical supervisors when working with substance use disorder counselors. And these, we're just going to call them non-urgent, urgent, and 911. So we have these weekly or bi-weekly supervision sessions, situations that are more seasoned counselors have learned to bank until their scheduled sessions. They're just non-urgent. Then there are the situations that require a phone call or a drive-by, where they just come and knock on your office. Please return the phone call when you're able to, sort of at your earliest convenience. The last situations are generally 911 and be willing and they'll call you or knock until you answer your door. Our less seasoned SUD counselors will tend to put all situations into this category, and they'll over time learn where these things go. And our job as supervisors is sort of to help them compartmentalize these things. As supervisors, we tend to tell them or try to show them where these things go. Red light, yellow light, green light, or category 1, category 2, category 3, or otherwise over the course of time, it will drive us crazy. And that is not to tell them that all situations aren't important, but by showing them where they can find resources to answer their questions, it'll help us in the long run, right? So that might be other counselors in the office, other seasoned counselors in the office, people who may know answers, or this could be an email, or this could be a voicemail, or this could go to the office clinical supervisor, etc. We'll talk for a second about group supervision and the value of group supervision. With this, we have an agenda, the value of an agenda, the way that the supervisees can email ahead of time to add something to the agenda. When supervisees know they can add something to the agenda, they feel part of the process, and that is important. It's important to have a value of a time frame that folks can count on, whether it's an hour or 60 minutes, 90 minutes. It's important to stick to that agenda. If they stick to the agenda, folks know that they won't try to wrap up early, and they generally won't try to drag things on. If you try to keep things to that hour and try not to drag things on either, that means that you won't stay longer or keep things less time. That means you honor their time and honor your time as well. It keeps things important, and folks know they can count on it. That's very important. I try to keep things in group supervision to a formula. Generally, it looks like 30, 40, 30, which we have 30% announcements or things that the team needs to know that I know. 40% is a teaching or revisiting of a lesson based on what's happening, or we turn that into clinical staffing matters. And then there's a 30% I call the house is on fire, or it's supervisees venting about what's going on in their clinical lives or the lives of the agency, sort of relieving pressure on the pressure cooker that lets people feel like they can vent and they can let things off their chest. But we try to keep all of this to whether it's a 60 or a 90 minutes. But it's important to keep that to the 60 or 90 minutes and not to let it go over and not to go under. I think when people get busy and they get understaffed, supervision starts to turn into, hey, do you got anything? Okay, I don't have anything. Let's just quit for the day. And if people know that that's what they can do, then they tend to not bring things to supervision. That's not what we want folks to do either. This is what we have at Serenity Lane. This is very important. As you can see right here, we have the compliance officer card. This is a compliance issue, in addition to the fact that it's just best practice and it's something that we should be doing anyway. There are several categories. Obviously, right here, we want to have our date, who the supervisor is. There's a drop-down menu on all of this on the spreadsheet. The only thing that we need to put in this value right here is F to face or virtual or group, how long of a time period this was, what the topic was, and notes off to the side right here. Here's the area of discussion that it could be. Any one of these things right here. There's some more. Oh, no, there is. I'm sorry. Any one of these right here, we can put as the topic areas. It's a really easy thing to put. Please notice what it says right here about do not include confidential personal issues. It's important because this file right here could be accessed by other people, but whether it's group or face-to-face individual or virtual, it needs to be documented because this is part of our compliance. And this is what Emily is going to make sure that we are doing like we're supposed to. Here's how I structure, or I try to structure, some of my individual supervision time. And I really hope 2020 adds up to 100. Good. 20% of my time is just a brief review of goals from our annual review. So we went over goals from the last review, updates from the last time we had our supervision session. So hopefully at your employee review, you talked about things that you wanted to do, the supervisor wanted to do. So for instance, they wanted to get their QMHA, or they wanted to get more training in an area. So these are things that we wanted to go over to make sure that they got. So 20% of their time in supervision, I want to touch on concerns from their last supervision session, perhaps patients that they talked about, or group concerns that I touched on, or concerns that I had, some multicultural considerations, or a training issue, or maybe I was Emily let me know that they were behind on some Relias stuff. I want to spend, if it's needed, 20% of my time on emergent concerns from this week. What are some concerns for this week? What are things that I'm worried about or they're concerned about or anything as their supervisor that I'm concerned about? I want to spend a fifth of my time or 20% of the time on organizational OKRs. things that where am I at with the team? And in turn, is the supervisee seeing enough patients? Are they delivering enough billable service hours? And then 20% of my time, the last 20% of my time, what are they doing about professional development? Where are we going from today? And what are we going to work on until our next time that we meet? And this is where I might document some more of this like training stuff or their goals from their annual review. And if they've already met all of their goals, what new goals do we have? What new goals are there? Because if they already met their goals, fantastic. But what new ones are there? Because new ones are great as well. So that pretty much wraps it up. If you have any questions from here, please reach out to me, your program manager, clinical director, wherever you're at, or anyone else on the executive team can help out. Anyone in leadership is happy to help you with questions or hearing ideas. Thank you so much for your time and attention. I really appreciate you stopping in to listen to this training. I'm always happy to hear your ideas or to hear any questions that you may have. Thank you very much.